Good morning, dear colleagues. As I see you are here, I'm glad to say hello. Dr. Wilson, are you here, yeah?
Dr. Wilson, please, are you there? Please confirm.
Can you hear me?
Yeah, good
Yes.
morning.
Morning.
Hi.
Okay, perfect. So after 5 minutes, we will start according with our schedule. And after step by step, we will continue. Thank you.
Mm.
You will tell me
Please
when.
allow. Yeah. Yes, please go ahead.
I think after 5 minutes, but
In the meantime, would you allow me to introduce Dr. Wilson?
yes, of course, Dr. Singh, I will give you time for speech. Yes, of course.
Yeah. Thank you. I know Professor Wilson for the last 2 decades.
Wow.
He's a extraordinary human being, very gentle, general, and genius. And he has been very, very generous in giving knowledge, delivering knowledge to experts in very many countries. And he must have come to India almost 6-7 times by now. He has been educated in biology, human biology, and he did his master, and then he entered into cancer chemotherapy and cancer diagnosis epidemiology with Professor Griffith. And he continued up to his retirement in that very area, and attending various meetings, interacting with us. Also, he has been a continuous, I think, more senior member than me with Professor Hallberg. Although I know Professor Hallberg from 1989, but perhaps I could not continue interaction and collaboration up to 1995. Only after that, and Wilson is attached with him from that very time, or maybe before me. So I would now request Wilson to say something about his experiences, and then after a few minutes, he can start his lecture with permission from Professor Yulia. Thank you.
You gave me a very good introduction, Professor Singh. I don't know how I can better that myself. but I have in my life two gurus. And the one that I beg your pardon, the one we are giving a tribute to here is Professor Franz Hallberg, who shares the same birth date as myself, although I'm not of his age. I've worked in many areas, many fields, and got a few, but I don't know, 450 publications in a wide range of subjects. So I await your call. But thank you very much, Professor Singh, who I might applaud for his dint of professionalism and efforts in the time that I've known him for the last more than a decade. He also is an exceptional person. Thank you. While I'm awaiting, if I may, I'd also like to applaud Professor Cornelissen, who decades ago was Franz Hallberg's lieutenant, and now she is a general in her own right. I applaud Jermaine very much. Thank you. Can you still hear me?
Yeah. Yes, yes,
Good.
yes, Professor.
It's now 7 o'clock. Shall we start?
Yes,
Can I start now? Right.
yes, 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 please.
Okay. Well, first of all, I would like to thank the organizers for inviting me to this conference. It is very much appreciated. And being a long-term friend of Franz Hallberg, it gives me great pleasure in giving this esteemed tribute. And I've chosen the topic sorry, I beg your pardon, I use I should delete that from the English language. We have chosen to talk about chronoastrobiology in the context of a universal biology, which Franz started some decades ago. So this is my old institute, the Tenerife Institute for Cancer Research. This is where I worked in Minnesota, and this is where I visited Professor Singh to do research. this, we all link together. And my old guru, Professor Griffiths, was actually met Franz Hallberg in Minnesota way back in 1960. So there's a cycle of friends here and ardent researchers together working as a team. Here you see this motto was shown before. It was Franz Hallberg's motto, measure what is measurable and render measurable in time what as yet is not. This is always attributed to him, but I am informed it was attributed also to Galileo, according to Giovanni dell'Acqua in Rome. So let me continue.
Without the tempestive.
Pardon?
Without the tempestive. Not in time. The in time is Franz.
In time, thank you, Jermaine, thank you. Thank you for that rebuke. Okay, so let's now look at this. The universal, this is a lot of information on the slide, so I'm going to actually kick out of here so we can actually see the words better, if you forgive me. So there's the scheme, universal biology, and chronoastrobiology fits in here. And I remember Franz talking about intergalactic life and mentioning possibly Andromeda. And this is the universe here, Laniakea supercluster, going to the Virgo supercluster and a local group in the Milky Way. And in the Milky Way, there are potential habitable super Earths, which could be of value to us in the future years. And there are over 1,000 super planets which we can find here. So we can't travel much outside the Milky Way and certainly only located within our solar system. So we divided this up into life on Earth. So a few points, just life on Earth, imprinting, early evolutionary life. Somehow, as yet, still not unclear, but we have imprinting by the sun, Helios on Gaia, Mother Earth, and Gaia now responds. And the imprinting, there's a reference here to early imprinting by Spaulding. And another point is the KP Geomagnetic Planetary Index, which measures solar particle radiation by its magnetic effect. And then Franz is, I beg your pardon, when I say Franz, I'm not being disrespectful. I really mean Professor Franz Hallberg. So Franz actually coined this term near transyear, and here you can see the definitions. It is approximately longer than a calendar year, but shorter than 1.2 years, as well as the far transyears, which is, as you say, defined here, within 1.9 years. And here's a little diagram here which shows how the imprinting works. Sorry, diagrammatically, of course. And here you see the modulator, the sun, Helios, Gaia, the Earth, the actor, and here's the biological, actually, reactor. So that's how we believe the evolution has worked up until the present day. Here is the interplanetary life which may occur in Mars. This is a reference 10, which in the text I think she's reference 11, which talks about Yellowknife Bay in the Gale crater in Mars. And life might be in Mars, Europa, which is Jovian moon, Enceladus, and Titan, based on certain information on criteria of ice, water, hydrothermal beds, methane, and complex organic molecules, etc., etc. So that's the criteria of why we think life might be on these bodies. And if we look at the astronauts' health, because we have to travel either a short distance or long distances, all of course distances relative, and of course cardiac monitoring of blood pressure and heart rate is important because there are sun flares and magnetic storms. Cataracts increase the risk of because space radiation has a higher energy transfer than terrestrial radiation. And people have to live together and work together and so forth. And mood and psychiatric disorders, eating problems, bone density loss, are all such factors we must consider. So biosignatures, when we're looking for life in other planets, we must be looking for activities which indicate life, like us. We have our urban areas, but there may be other things like biomass. We have our cliffs, sedimentary rocks, etc. But we have to think wide, outside the box, because if we're looking for structure, we don't know what we're going to find. There may be reservoirs of biomass and waste, minerals, atmospheric gases, etc. And finally, just on this slide, Tversky and Broy stated that life on Earth is an echo of the sun, and the vital force theory may be revisited. It is revisited, the vital force I first thought of even when I was 8 years of age. I've just got to turn now to the current slide, and we'll click over here. I have to talk about the universe in general. You know the Kobe program, and this is the micro radiation picture that you get showing the structure of the actual universe. And look at the size of it, 93 billion light years. And as we go through, we live just about where I put my arrow, and there, and that's the Laniakea. There's, go through the supercluster, Virgo supercluster, local group, to the Milky Way. And the Milky Way is only 200,000 light years, massive distance. And here's the Earth-Moon magnetic field. But the Earth-Moon magnetic field, not of today, but of 4 billion years ago. And here you see a rough indication of the timeline of life on this planet and the interstellar wind. So that's the framework. And I couldn't go to this conference in Moscow not mentioning Tsiolkovsky and Fyodorov, two eminent Russian space experts in the early years. These were pioneers, is the word to use, which ultimately launched Gagarin into space, and as a result of sort of international competition, I guess, helped to put a man on the moon with the Americans, Neil Armstrong, Michael Collins, and Buzz Aldrin in their Saturn C5 rocket. I don't think, but the importance in the environment of electromagnetic waves is indicated. A lot of animals actually use magnetic fields or polarized light to actually navigate. And some of you may think this would appear to be back to front. I prefer it the other way, but this diagram shows you the range of actual frequency of these electromagnetic waves. You get an idea because the blue is this side, higher frequency, and the red is that side, lower frequency. Please forgive me because I'm colorblind. So if we look at this diagram, I'm going to pop out of the talk for a minute so that we can see it a bit better. Here we see the Earth history. The moon was formed about 4,500 a million years ago. And it was formed presumably as a result of a severe collision, and life formed a little later. Here you can see the prokaryote cells, eukaryote cells. And if I turn my attention, if we turn our attention to, I move this just a little bit over, you can see what I mean. This is the lower universal common ancestor, and the lowest eukaryote common ancestors. So this area about here corresponds to that area here. And it's amazing how there was such a rapid expansion in the Cambrian era. This is the Cambrian era here. This is the pre-Cambrian era. The Cambrian era is amazing in terms of its flourishing and diversity. And what happened here is, I'm not really quite sure why there was such a diversity. It could be because of oxygen, but I don't know. There's something must have triggered it off, and I'm not really sure what the trigger is, and I'm not quite sure whether other people really unambiguously know what it is. So let's return to the slide. And some of you have seen this slide before. And this is what we'll be looking for out in our space journeys. We're looking for constructs like the stromatolites. These are cyanobacteria, which occurred about 3,500 million years ago. We might find something like this, but it might not be carbon based. It might be silicon based or some other metal, depending what is around and can utilize the energy and utilize nutrients of a sort. Thank you. Now we look at this slide, which is very interesting, because here's our current 365 days in a year, approximately. If you go down, say, for example, to this one, the lower Silurian, where you trilobites and were in great profusion, you can see that the length of day, there were 421 days in a year. And that, with a bit of calculation, that would be about 9/11 times 24. So that would give you about a 20-hour day. So the Earth was spinning at has a 20-hour day, which is important. The Earth was spinning faster then than what it is now. And the moon was closer. And years ago, it had a joint sort of magnetic field, which it hasn't got now. So here's sunspots now, which are very important. The sunspot is massive. It's about 10 times the diameter of the Earth. And it's actually caused by changes in the convection in the sun, which, if you like, pulls down the heat into the inner surface, and so it is cooler. But the important thing about magnetic storms is this effect, for example, on myocardial infarction. And you can see that in the equinox, there's a 75% change, percentage change, incidence change, compared with the summer, compared with the winter. I think these data combine the two equinoxes. So let us go to, that's the important thing was just talked about in this conference early on. Sunspot variation. So we have a period of very roughly 11 years. And here you see 400 years of observation from about 1600 to about 2000. You can see the blue is actually quite detailed for its time in terms of observations. But the bottom line is interesting because it is based on dendrochronological dated radiocarbon concentrations. And you can see going back to 10,000 years BC. And let me just put that back in. This is important because nothing is stable. One must remember that the Earth's magnetic field changes. It changes in intensity and the dipoles change. Indeed, in the Earth's history, based on sediments in the ocean, the poles have been known to flip over from time to time, all to do with the convection of the liquid in the Earth's crust, in the center of the core of the Earth. Let me go to this one now. Here we look at terrestrial magnetic indexes and the biosphere. And you can see that the odds ratio for diastolic temperature, heart rate, systolic, vigor, mood, and you can see there's a relationship in terms of risk and congruence with the antipodal geometric disturbance. If you go from terrestrial magnetism and biosphere to interplanetary index and biosphere, you see a similar sort of actual pattern. And this is the work of from the Hallberg Center in Minneapolis. And so is this schema, which basically needs no introduction, and basically point estimators of limited value. But when confidence intervals overlap, overlie or overlap, there's congruence. And you get similarity when they're not quite overlapping, and so on. And the next slide shows the congruence of the solar wind speed with heart rate and blood pressure. Here you see the solar wind speed, that's the upper frame. I think if I actually end the show here, and that's right, that's what I wanted. This is better to see. It's too much information on this slide, this series of slides, but there we are, that's how it is. So here you see this solar wind speed, systolic blood pressure, the amplitude and frequency, and you can see the congruence here as identified in this slide for systolic blood pressure by Franz Hallberg, and also diastolic blood pressure, Franz Hallberg, and similarly heart rate, I believe it is, yeah, heart rate. And there's a reference by Jermaine Cornelissen and Hallberg. So if we go to the next one, and so I'll just, okay. I think you can read that. No, you may not be able to read that, I'm sorry. Too much information on the slide. You can read that. So just some broad segments of investigations which have occurred. Sorry about my throat. I've got a rasping throat. I don't know if it's because I've been up and talking to myself or not. But the origin of life, that's what we're concerned about. And so we must be looking out there in space at the origins of first here to learn whatever we can, integrate as much detail as we can, as we have done in the Urey Miller experiments, clay experiments, and information from deep submarine hydrothermal vents, such as those off the Gulf of California. UV protection in a cold world 3 billion years ago, the influence of the magnetosphere, Earth and Moon, prebiotic and chemical evolution, etc., etc. And then we could, Earth is a template for chemical interactions based on water, as we know, and polymers of living molecules. So that's what we must look for on Venus, on Mars, or wherever, as we go from the future into the future. So here are some key points for investigation. Look at the electrical energy and hydrocarbon in the media. Look at perhaps primitive batteries wherever they may be found, such as in the ocean. And the biochemistry is concerned with movement, and of course gravity and buoyancy, and the effect of glaciers in Precambrian era, and so on. And this is panspermia, Arrhenius and people long before him by the Greek Anagoras. When we come to coronal astrobiology, as part of the universal biology, we could talk about the sustainability of health, the impact of the environment on Earth population, space travel, extraterrestrial habitation, new models of evolution of life, biosignatures, etc., etc. So we must build together a roadmap and plan and a timeline. So put together, that's not quite right. Put together because Franz Holbert has already started with his BioCause program. He started this plan of looking outside the box, looking out there at the sun and the solar system and beyond. So we must look for life, and when we look on life on Earth and the cosmos, the future of life on Earth and cosmos, we must have tools for manned spacecraft, unmanned spacecraft, robotic missions, telescopes in space, new sensors, accommodating impending catastrophe, survival of the human race, which is probably doubtful. Okay, so there's a whole list of things one might incorporate into a roadmap. I'm sorry about my throat. So if we look at continue on, let's put that there. And so magnetism and resonance are extremely important. I won't dwell on this too much, but we have to, well, how does magnetism exert an influence on life as we know it, not necessarily as it exists elsewhere, but certainly resonance appears to be involved in relation to the brain and heart nervous tissue resonating with geomagnetic frequencies. So let me move on. So here we go with life, the process of life and examples. Right at the top of the list is clocks and chronome structure for metabolism, adaptation, growth, response to stimulation, etc., etc. And I always like this one by Carl Sagan, the self-sustained chemical system undergoing Darwinian evolution. That's a simple one for people to understand, but it's not top of the list. And of course, we have life consists of plants, animals, fungi, protists, archaea, bacteria, and viruses maybe. And all life has energy requirements and nutrient requirements. I'll push that back. And from the age of 8, and I didn't use these words I always concerned about the vital force. When I saw a dead dog lying on a mud bank by a stream and gradually where there was once life, and when after a few weeks it disappeared and went into the environment, that had a lasting effect on me. And so I still think of the vital force. What is the difference between the inanimate and the animate? And here you see a reference which I wrote for Professor Roel van Strikt in his Amicorum. So that's my time might be up now, so I'm nearly finished. So in the context of universal biology and space environment, we've got to consider space travel and bases. For example, on the base in the moon, the Shackleton base in the south pole of the moon, if it comes to fruition, if it comes to be. And then so yes. Okay, I'll finish now. Okay, I'll just close then. But finally, I want to close this last paragraph. The BICOS program was launched here in Russia, in the Russian Academy of Medical Sciences, way back in 1997, with the Russians and obviously Professor Franz Holberg. And my last slide, I attribute this verse saying, all truth passes through three stages. First, it is ridicule. Second, it is opposed. And thirdly, it is self-evident. Thank you, ladies and gentlemen, for your attention. Thank you very much.
Thank you, Professor Wilson, for your interesting presentation. It's a pleasure to hear you. And dear colleagues, do you have some questions to our professor?
Yeah, excuse me. I enjoyed your talk very much, Professor Wilson. I would like to know whether moon eclipse or the sun eclipse have an effect on blood pressure variations. Thank you.
I don't know, but I would assume that it's a very important area to investigate, because actually fish in the oceans and birds and other wildlife respond to lunar light. And I think that's a good idea, Professor Singh.
No, you know it. Perhaps at this moment you may not be able to remember, but you know it because we have been discussing this earlier.
Oh,
Yeah.
Thank you for the rebuke.
Right.
Okay. According with our schedule, next our lecturer is Dr. Ghazi Halabi, but I'm afraid he is not here today. Yeah, I did.
Problem in Lebanon.
No, he's not here. I checked already, and I'm afraid not.
Yeah.
So maybe, but sometimes, yes, of course, it's some technical problem and it's not easy. So I want to ask, is it Etienne Chalet is here?
Yeah,
Yes.
Yes.
I'm here, yes. Good morning, everybody.
Yeah.
Yeah, good morning.
Good morning.
So please, yes, your turn.
Okay. Can you see my slide?
Yes, please.
Okay. So good morning, everybody. I'm Etienne Chalet from University of Strasbourg in France. So first of all, I'd like to thank Professor Sergei Shibitsov and all the organizing committee for giving me the opportunity to talk to you today. So the purpose of my presentation is to discuss with you the role of hormonal rhythm in mammals. So as an introduction, I'd like to remind you that the circadian timing system comprises a multi-oscillatory network, actually, with a master clock in the suprachiasmatic nuclei, the SCN, and a number of regulators and clocks in the brain and in most peripheral tissues. Here on this scheme, you can see the model proposed to explain how the clockwork can deliver rhythmic message, using in particular the rhythmic expression of clock control gene that deliver local and systemic temporal cues that will be transmitted to other organs within the body. So actually, there are a number of hormones that are rhythmically secreted in the body. For instance, as you probably know, melatonin secreted by the pineal gland at night, cortisol, which is secreted at dawn, and also, for instance, leptin, which is secreted from the adipose tissue with a peak at dusk. So the question I'd like to ask today is whether hormonal rhythm can be internal time givers. In other words, can they convey some temporal information within the body? Let's start with melatonin. So melatonin in both nocturnal and diurnal species is always secreted at night. So this corresponds to the sleep period for diurnal species and humans, and this corresponds to the active period in nocturnal animals. On this scheme, you can see that melatonin is synthesized from the tryptophan, and the trigger stimulus is the release of norepinephrine that will activate this synthesis. And norepinephrine is only secreted at night under a tight control of the master clock. This is why melatonin is always secreted at night. So now on this slide, you can see the synchronizing effect of melatonin. In that experiment, nocturnal rats and diurnal rodent, that is called abicanthis, and that we breed in Strasbourg, all these rodents were housed in constant darkness, so they were free running, you can see here, and they receive a daily infusion of melatonin. On the left, in the nocturnal rat, you can see that there is a synchronization when there is a coincidence between the timing of perfusion and activity onset, that is the beginning of the active period. By contrast, in the diurnal rodent, there is a synchronization of its sleep-wake cycle, of its rest activity rhythm, when there is a coincidence with perfusion of melatonin and sleep onset. Okay? So this experiment demonstrates that melatonin can entrain the master clock always at the same circadian window, that is at dusk. But of course, this occurs at opposite sleep stage between the two categories. Other studies have shown that melatonin can also synchronize peripheral clocks, such as the white adipose tissue, but I'm not going to illustrate that today. So let's move on now with glucocorticoid secretion. You can see on that scheme that in contrast to melatonin, glucocorticoid rhythm are opposite in phase between diurnal species and nocturnal species. In diurnal species, such as the abicanthis or human, there is a peak at dawn, while in nocturnal species, such as lab rats, mice, hamsters, there is a peak at dusk. One of the explanations to explain this switch between these two patterns of secretion may reside in the paraventricular nuclei, PVN, because the PVN receive temporal message from the master clock in the SCN, in particular vasopressin, which is released in daytime, and this vasopressin has actually opposite effects. It is stimulatory in diurnal species and inhibitory in nocturnal species, suggesting that all the downstream components of the HPA axis then function opposite in phase. Now let's consider the synchronizing effect of a glucocorticoid. First observation, the master clock does not express glucocorticoid receptor. Therefore, glucocorticoid do not have a direct effect on the master. However, this doesn't mean that rhythmic secretion of glucocorticoid have no temporary synchronizing effect. And as an example, here the Raphe nuclei, which is the main site of synthesis of serotonin under the control of the enzyme the tryptophan hydroxylase. And the expression of this enzyme, TPH2, is rhythmic in the Raphe. You can see here the strong expression of this RNA coding for this enzyme. The question here is whether the daily rhythm of corticosterone being the main glucocorticoid in rats, in nocturnal rats, does this rhythm play a role in this rhythmic expression? There's this hypothesis, rats have been adrenalectomized, and indeed, there is a disappearance of the rhythmicity in the expression of this gene. However, if these adrenalectomized rats receive a rhythmic message of corticosterone via drinking water, you can see that there is a restoration of the rhythm. This experiment for the Raphes therefore demonstrates that circulating glucocorticoids can strongly influence rhythmicity in brain region. I show you here the example of the Raphe, but other studies have investigated, for instance, amygdala, oscillation in the amygdala. And other studies have also found similar properties on peripheral organs, such as the liver and the white adipose tissue. So now let's move on with the third example, which is the rhythmic expression of leptin. Leptin in nocturnal rats display a peak during the night, while in diurnal rodents there is a peak in late afternoon, and in human it is even a bit late. So now let's consider whether leptin could play any role in the internal time. To test this hypothesis, we have studied mice, the OBOB mice that have a mutation in the gene coding for leptin. Therefore, they do not synthesize leptin. And we have compared daily rhythmicity in lipid metabolism to see whether leptin could play a role in this rhythmicity. And what you can see on this slide is that free fatty acid or high-density lipoprotein display a rhythm in OBOB mice. Even if the level might be different, you can see that the oscillation are more or less in phase with the oscillation in control mice that are heterozygote for the mutation, indicating that leptin doesn't modulate the rhythmicity in lipid metabolism. What about glucose metabolism? In that case, there is a clear inversion in the daily rhythmicity of blood glucose. There is a peak in control mice in daytime, while in OBOB mice, there is a peak at night. This inversion is not due to an inverted food intake, as you can see in the middle panel. And interestingly, in another model of genetic obesity and diabetes, the DPDB mice have also an impaired leptin signaling, but in that case, they synthesize leptin, but they have a mutation in the leptin receptor. Therefore, leptin is secreted, but it cannot bind to its receptor. And again, we have a peak in control mice in daytime and an inverted peak with maximal value at night. This first experiment therefore indicates that leptin indeed participates in the control of the daily rhythmicity in blood glucose. Next, we wonder whether a repeated time injection of leptin may affect either glucose rhythm or food intake. For that purpose, OBOB mice were injected daily with leptin, either in the morning or in the early evening. For glucose, we found that morning injection actually lowered the level of blood glucose as expected. However, we didn't detect any rhythm in glucose. By contrast, there was a phase delay in the food intake feeding fasting cycle. regarding early night injection, we found that of leptin, we found that they induces a phase advance of the glucose rhythm, in addition to a lowering of mean blood glucose, as well as a phase advance in the feeding fasting cycle, indicating again that time cues associated with leptin induction can modulate daily rhythmicity of blood glucose and feeding rhythm. Next question was to determine whether leptin can modulate master clock and possibly its synchronization to light. To test this hypothesis, we have studied mice, control and OBOB mice, exposed to a light pulse in early night. Here on this actogram, we can see that a light pulse, as expected in early night, produces a small phase delay in the locomotor activity rhythm. And the same light pulse in OBOB mice produce larger phase delay. This is summarized here. Next, we injected leptin in control mice before the light pulse, and we found no effect, no differences between the control mice injected with vehicle, probably due to a sailing effect, because at that time in early night, the endogenous rhythm of leptin is starts to run. Interestingly, in OBOB mice that receive a leptin injection prior to the light pulse, there was a normalization of the response, suggesting that leptin is somehow able to regulate and to modify the synchronization to light of the master clock. To check that, we investigated the molecular response directly within the master clock using the CFOS expression as a functional marker. And as expected, a light pulse at night produced a very strong expression of CFOS in these OBOB mice. And the treatment with leptin prior to the light pulse decreased and reduced the response of the light. And then we wanted to know whether these effects were direct on the master clock or more indirect. So for that, we used a functional marker of leptin and cytokine signaling, which is phosphostat 3. And we investigated the expression of this marker after leptin injection, either in the mediobasal hypothalamus, including the arcuate nucleus, the VMH and the DMH. And you can see that indeed in OBOB mice, there was a strong increase in phosphostat 3. By contrast, in the same mice, in the ACN, we found no differences, suggesting to us that circulating leptin is primarily affecting the mediobasal hypothalamus, that in turn modulates the synchronization to light of the master. So as we have seen, indeed, they are hormonal rhythm, and indeed, they are internal time giver. They play a role in the temporal organization within the body. And although each of these rhythms might not be critical, altogether, they contribute to proper internal time. Now, I would like to briefly mention possible causes of alteration in this hormonal rhythm. For instance, eating at night may increase leptin secretion and also may increase other metabolic hormones, for instance, such as insulin. Furthermore, of course, stress will increase glucocorticoid secretion, and especially during the daily drive. Also, light at night is known to immediately inhibit leptin secretion, and depending on light intensity and light duration, light at night may eventually totally blunt the nocturnal secretion of melatonin. And in these cases, altered hormonal rhythm may become desynchronizer, because if you lose this hormonal rhythm, you may lose their temporal effect on internal time. Now, as it has already been mentioned several times in this meeting, They are reciprocal interaction between metabolic disturbances, such as diabetes, obesity, and circadian disruption. And this is an important societal question because more and more people are exposed to shift work or to chronic jet lag. And according to the data that I showed, it is likely that altered hormonal rhythms may contribute to circadian disruption, hence impacting metabolic health. Furthermore, timed endocrine therapies may promote phase adjustments by targeting the master clock, for instance, using melatonin agonists, or by targeting circadian clocks in the periphery, for instance, with by using glucocorticoid agonists, or more simply, by a timed meals that will also resynchronize metabolic hormones. With that, I've reached the end of my talk today. So I would like to thank my colleagues in Strasbourg and abroad also, the funding here. And I would like to finish with an advice: to be healthy for a long time, take care of your circadian rhythmicity. Thank you for your attention. If you have any question, of course.
Thank you. Thank you, Doctor, for your interesting lecture. Dear colleagues, do you have questions, please?
Thank you very much. It was a very interesting talk, Etienne. Can you amplify on your thoughts? To what extent do you think those hormonal backups of some kind might constitute like redundancy of the circadian system, and to what extent could they take over if the suprachiasmatic nuclei would no longer function?
I'm not sure to get the point.
There is a lot of redundancy in the organism. So to what extent do you think the suprachiasmatic is really absolutely indispensable, or are these hormonal mechanisms some kind of a backup system?
In normal condition, indeed, the suprachiasmatic nuclei are very important because they are the conductor of all the peripheral clocks. However, if ever the SCN are not functional, it might be possible by timed cues. I'm thinking, of course, of restricted feeding. You can resynchronize all these peripheral clocks, and then they will do the job of the master clock as a conductor. But yes, this is what I can say.
There is in the literature some papers intimating that there may be some other mechanisms in the brain that might also contribute to the circadian rhythmicity that we see independently of the suprachiasmatic nuclei.
Yes, maybe, but because the suprachiasmatic is at the head of the system, it is very important.
May I
You
ask
know,
a question?
very early, of course, at that time, the techniques were quite different, but very early in his career, Franz showed, for instance, that certain rhythms could persist even after suprapontine ablation. Similarly, if you did an adrelectomy, some rhythms persisted, but some others also no longer were detected.
Yes, I know, but I mean, the robustness of the system is a redundancy. probably because it is very crucial for survival. But I agree with you that there might be some independent regulation, but in normal condition, they work together to produce a stronger rhythm with stronger amplitude.
It was a really interesting talk. Thank you.
Thank you.
I enjoyed your talk very much. I'm Dr. Singh from India. I would like to know whether which glucocorticoids are responsible for regulation of the amygdala activity, because recent research by functional MRI has shown that it is the amygdala that regulates almost all the components of the brain, and in relation to neurodegeneration and also psychological disorders. Please.
Okay, so this I mentioned the work on amygdala indeed, and this has been done by in nocturnal rats. So they studied it. It's a work done by Shimon Amir in Canada, and they studied the effect of corticosterone in that case. But we can suspect that the same kind of regulation occur in humans with cortisol that would modulate the rhythmicity in the amygdala. But I'm not aware of any studies in humans on cortisol.
Some of the chronobiologists and the neuroscientists feel that the interaction of amygdala and the circadian clock could be bidirectional. Some stimuli from amygdala or increased amygdala activity causes inflammation, and which might initiate, stimulate or activate the circadian clock. So is it like that? Can you comment on this? A bidirectional interaction between circadian clock?
I would say yes, it's quite
brain?
possible, but
Yeah.
I cannot say more. I mean, we have to test this hypothesis.
Yeah. Of course. Thank you very much.
Can I ask?
Yes.
Can I ask a question?
Yes, you can.
It's Alexei Nyushkin here.
Hi, Alexei.
Thank you very much for your quite impressive lecture. And my question is about insulin. You mentioned it on your scheme, and what's your opinion about the insulin? Can it entrain circadian clock of the SCN and how it works? Do you have any new data from your lab? So that's the question.
Okay, thank you for the question. So yes, indeed, I mentioned insulin, but I didn't show any data. So apparently, according to what we have done in my lab and to published work, insulin does not act directly on the master clock. Probably because, I mean, I don't know exactly why, but insulin might be very important for the effect of food synchronization. When we eat always at the same time, there is a postprandial peak of insulin, and this postprandial peak seems to be very important to synchronize the peripheral clocks, possibly in the brain, outside the SCN, and also in all peripheral tissues. But it seems that, according to what we know right now, there is no synchronizing effect of insulin on the master clock. It doesn't mean that insulin does not act on the SCN, but no synchronizing effect. This is what I can say.
Okay, thank you very much.
Thank you.
Thank you again, Professor Chalet, for your interesting lecture with many questions from our audience. So, our colleagues, do you have some other questions? So, if not, thank you. And I want to ask, is it Chonti Chisha Tanking? Is it here? Because she sent me her presentation, but I can't see her. No. You can see. Okay, maybe we will waiting. Maybe she will come later. Yeah, Professor Singh, what do you think? Okay, Gizal Fatima, I can see you. Yes, we are preparing so long time. So please, now is your turn. Please, you can start. Can you can you share your presentation with us?
No, it's with you. Please open it for me.
Yeah, okay, you want that I will. Okay, wait a second, okay?
The one I send you right now. The one I send you right now.
Okay, I will wait. I will open your presentation.
The recent one.
Yeah, I will. 1 minute. Yeah, I will do it now. Mhm. 1 minute. Mhm.
Yeah, thank you so much.
1 minute, 1 minute, 1 minute.
Okay.
Please.
First of all, can you hear me?
Yeah.
Oh, first of all, I would like to thank International Scientific and Practical Conference, Chronobiology in Medicine and Sports. Thank you so much, RB Singh, sir, for inviting me to attend this virtual conference on chronobiology. And I thank all the organizers, especially Yuli also, for such a wonderful conference. Now, my topic is circadian dysfunction in fibromyalgia rheumatica. I'm assistant professor in Department of Biotechnology here in RUDN University, Lucknow, India. So what is fibromyalgia syndrome? Fibromyalgia syndrome is a rheumatic, please change the slide. Please change the slide. Yeah, it's a rheumatic disorder that is characterized by chronic muscular pain with no obvious physical cause. And it's a systemic condition. Fibromyalgia syndrome is a systemic condition, one that affects the whole body and also can cause organ to not work properly. Please next. Next slide. Next. Julia, please next. Yeah, symptoms of fibromyalgia syndrome. Please next slide. It has symptoms like chronic joint aching and stiffness, dizziness, palpitation, soft tissue swelling, sleep disturbances, pain, fatigue, primarily upon waking, and anxiety and depression. The causes for fibromyalgia syndrome is really unknown. The etiology, it has trauma, infection, hypothyroidism, genetic, and also maybe hormonal disturbances. Symptoms of fibromyalgia syndrome basically include, Yulia, please next slide. It's pain, sleep disorder, fatigue, stiffness, allodynia, and paresthesia. Prevalence, over 2 to 4% of Indians suffer from fibromyalgia syndrome, and 90% of them are women. Diagnosis is, it is diagnosed based on American College of Rheumatology criteria, having 18 tender points locations which are painful to pressure, widespread aching for at least 3 months, and chronobiological disturbances circadian rhythm disturbances have also been observed in melatonin and cortisol in fibromyalgia syndrome patients. The circadian rhythm that regulates the amount of hormones and neurotransmitters the body produces, and by this, it creates circadian rhythm imbalance. In fibromyalgia syndrome, there is alternation in hormonal and neurotransmitters productions. Therefore, this study is conducted to study the relationship of fibromyalgia syndrome and circadian pattern of release of hormones and cytokines in fibromyalgia syndrome patients. Please, next slide. The clinical assessment of patients and controls, we enrolled 50 patients and 50 controls for this study. All the clinical and biochemical assessments of both patients and controls were done. And characteristics among the study and control groups were a study group for fibromyalgia syndrome patients, and here it was nothing to do with the sampling design. We did sampling design in a circadian pattern. In morning 6 a.m. we collected the blood, and then in the noon time, exact at 12 noon, and then evening samples were collected at 6 p.m. and midnight samples were collected at 12 midnight. Blood samples were collected at different designated time of the day. Please, next slide. Different designated times of the day, whereas collections were from 11 to 11:30 p.m. and at 6 to 6:30 a.m. The midnight samples of patients and controls were drawn and were kept for 30 minutes for serum separation, and then stored at 2 to 8 degrees centigrade for 6 hours, and then configured in the morning and stored at minus 40 degrees centigrade. Julia, please, next slide. Next slide. Next slide. Next. Yeah. Then circadian rhythm of serum cortisol we studied in study and control group, where we found no significant difference in the evening and nighttime pattern, but morning and afternoon samples were found significantly higher among the control group in comparison to the patients, whereas afternoon samples were found higher among fibromyalgia syndrome study group in comparison to the control population. Next slide. Julia, please. Yeah, next slide. Next slide, Julia, next slide, please. Yeah. Circadian rhythm of serum melatonin levels in a study and control group. Here, the here we found a very significant difference among morning melatonin levels, which were found to be higher among fibromyalgia syndrome patients, and midnight. In midnight, patients group were found lower melatonin levels in comparison to the control population. However, we found no difference in the afternoon and evening melatonin levels in both study and control group. However, the morning melatonin levels were found to be higher, and nighttime melatonin levels was found to be lower in patients of fibromyalgia syndrome. Next slide. Next. Serum melatonin levels were found to be higher, but there was no significant circadian rhythm changes found in serum serotonin level in both study and control group. Yuria, please, next slide. Next slide. We designed a questionnaire of circadian pattern of fibromyalgia symptoms in patients and control group both. We have assessed the circadian rhythm questionnaire, where we put the maximum pain and least pain morning, afternoon, evening, and midnight time. Patient had to mark the chart accordingly. We found maximum pain in fibromyalgia syndrome patients during the during the night time and the morning time. Most patient reported maximum pain during the morning and night time. Similarly, the maximum stiffness and anxiety and numbness and feel worst feel time were all reported during the morning and midnight time in comparison to afternoon and evening time. Next slide, please. And maximum stiffness and difficulty in concentration and maximum headache all were reported to be in the morning and midnight time in comparison to the control population and in comparison to the afternoon and evening time. Please, next slide. Thank you. This is what we have got after the circadian rhythm questionnaire which we designed. This is the exact pattern of circadian rhythm of symptoms in fibromyalgia syndrome. So at 12 midnight, there was, due to low melatonin secretion, impaired sleep was there, maximum numbness and worst stiffness, and maximum pain was also reported during the night time. That commenced till the morning time, and then that decreased in the afternoon, and then in the early evening it was all normal, but in the late evening the patients reported their most distressed period in the late night and the morning time. So during the 6 a.m. in the morning time, low cortisol levels and were reported by the patients, and by the blood test, and high stress were reported during the morning time. Maximum pain and stiffness and anxiety was also reported in the morning time. Immense fatigue and minimally patients reported their alertness during the morning time, and they also reported the difficulty in concentration, dizziness in the morning time. And during the afternoon time, like during 12 noon and after that, the patients reported daytime sleepiness and high alertness during the afternoon time, and feel good time was also there. Throughout the day, they reported that, yeah, they feel quite nice during the afternoon time, and least stiffness and fatigue and pain was also reported by the patients during the afternoon time. Headache onset then begins in the evening time. They felt quite fatigued, and then elevated cortisol levels during the night time with maximum stress and stiffness of the body. Then the clock follows the same. Please, next slide. Yeah, we did serum interleukin 6 levels in both patients and controls, and we found no significant changes in patients and controls in the interleukin 6 timing, and there was no significant difference observed in circadian rhythm of serum interleukin 6 in both the study and control group. However, it was found higher among quite higher levels were reported in the patients of IL-6. Please, next slide. Next slide. Thank you. Serum TNF alpha levels was also not found significant in both patients and control groups when we observed the circadian rhythm changes amongst them. However, in the pernile of inflammation, they were found higher when we talk about fibromyalgia syndrome only, not about circadian rhythmicity, because the levels were higher, depicting the inflammation in the body and the reflection of pain and fatigue and all other symptoms. But we didn't found any varied circadian rhythmicity in the interleukin 6 levels in fibromyalgia syndrome, and even in the control groups also. Please, next slide. Thank you. This is the higher cortisol higher interleukin-6 level pattern in different times interval of the day. However, there were no rhythmicity observed in TNF alpha pattern in different times interval of the day. Please next slide. Who are risk at fibromyalgia syndrome. Please next slide. The one, please next slide. One with a higher tension, headache, mass, depression, guilt and anguish, stress, and lack of quality of sleep. This is the most important symptom we figure in fibromyalgia syndrome patients, and constant fatigue or pain. That was all influenced by difficulty in sleeping and disturbed sleep quality in fibromyalgia syndrome patients. Please next slide. Thank you so much. This is a certain studies done. So 6 years prospective study of a cohort of patients with fibromyalgia by Baumgarten concluded that symptoms of fibromyalgia syndromes persisted over the 6 years, but patients appeared better by improving their sleep timing. Therefore, if the timing of sleep is improved in patients with fibromyalgia syndrome along with circadian rhythmicity improvement, they may have, the less worsening of symptoms and may also improve their pain and fatigue symptoms. Another study, which was done by Rizit Isomery in 2018, which is published in International Journal of Rheumatology, is severity of symptoms persist for decades in fibromyalgia, a 26-year follow-up study. This study concluded that symptoms of fibromyalgia syndrome have persisted in most patients for decades without significant deterioration of self-reported functional ability. That means the functional ability was not very much deteriorated. However, the symptoms have been persisted for long in fibromyalgia syndrome patients. We hypothesize that even the long-term symptoms may also be improved if the circadian rhythmicity of the body is improved. Another study, which was done by Maura Kennedy in 2018 on a prospective long-term study of fibromyalgia syndrome, they also concluded that fibromyalgia syndrome symptoms may last on an average at least 15 years after illness onset. However, most patients experience some improvement in symptoms after fibromyalgia syndrome onset who exercised regularly and slept on time. This is also a very important study depicting the exercising and sleep quality improvement may improve the disability and symptoms severity among fibromyalgia syndrome patients. Another study done on time-dependent pain in fibromyalgia syndrome explorative study, which was done by Lord Mod Landmark in 2019, that was resulted in more nighttime pain than in evening and noon time. This is the time dependent pain in fibromyalgia syndrome patients. They also marked that more patients reported more pain during the night time than in the evening and afternoon time. Whereas, please next slide, whereas our study observed that the abnormality in melatonin and cortisol, which are highly regulated by circadian pacemaker SCN, raises the possibility that there is an abnormality of circadian rhythm in fibromyalgia syndrome patients. Our study also depicted that circadian rhythm symptoms in fibromyalgia syndrome vary substantially throughout the time of the day. And this study therefore resulted in better understanding of circadian rhythmicity in fibromyalgia syndrome patients. The chronobiological theory that has important implications with regard to the treatment or management of patients with fibromyalgia syndrome. However, the diurnal variation of symptoms that suggested that the optimal midday time for the least pain and fatigue provides opportunity to promote and to monitor the response to treatment programs. And it has also very important implications in the assessment of the patients. Therefore, timing may be very crucial in treating diseases like fibromyalgia syndrome, and this has an important implications for scheduling activities of daily living, and also possibly for timing the administration of medications in fibromyalgia syndrome patients. Next slide. Thank you very much for being so attentive. I thank you very much, and I thank all the organizers, especially Dr. Yulia, for her unremarkable work in this conference. Thank you so much.
Hello. Hello.
Hello.
May I ask a question, Dr. Singh?
Yes,
from
yes,
India?
please, sir.
I enjoyed your talk very much, Dr. Fatima. I wanted to know, in your study, did you match your subject properly by age and sex? In the intervention group, you didn't find any circadian rhythm, circadian dysfunction of the cytokines. Actually, they should be raised in the morning compared to the control group at least.
Uh,
What could be the cause?
Sir, actually, I didn't find any changes in cytokines level.
Why did you should have examined these
It was
patients?
higher found. Sorry.
Yeah, they were higher compared to the control group, but not there was no circadian rhythm
Yeah, yeah, we
increased.
didn't find.
Yeah, but why did you not find? Did you try to analyze your data? Because some of these patients there might be very many confounders, protective factors. For example, in the morning, people might be doing exercise, or people might be doing prayer, or people might be eating a heavy breakfast. That might have allowed them to maintain their circadian increase in the cytokines in the morning. So I
Yeah,
think
maybe
they are in
I am not sure, sir, because we found changes in circadian rhythm in cortisol and melatonin. They were also, I mean, we didn't find any changes then also in them even, but we found changes in cortisol and melatonin. We didn't find any, I mean, changes in interleukin 6 and TNF alpha.
that
And I
also
cannot
is
explain this discrepancy.
it is the glucocorticoids that are responsible for inflammation, and these are the marker of inflammation. So they should have been raised. So cortisol and the cytokines, perhaps they go together. I think you should reanalyze your data and look for other confounders, which may explain
Okay,
this
okay, sir.
appearance.
We measured sex and other demographic data also. But yes, I'll do that again. Maybe we did late. We measured cortisol and melatonin immediately as we got our kits, but interleukin 6 and TNF alpha, we got bit late in measuring them. Maybe, I mean, the
Laboratory
storage
error.
of samples, timing may be long, or
Yeah.
I do not know other discrepancy that could be explained much easier than this.
What are the
Maybe,
results from other studies?
sorry, sir.
Do you have other studies, what they found? There might be other
Other
studies
studies,
showing.
yes, yes, some of them found changes in interleukin 6, but most of them didn't found any, I mean, a strong
So they also
relation, a
might
strong
have
circadian rhythm in
Please,
TNF.
Professor Singh, let to Dr. Fatima to finalize out her answer, please.
Thank you.
Please, Dr.
Thank
Fatima,
you very much.
you can continue and finish.
Yes, yes. Thank you so much.
No, you can answer, please.
No, it's all right.
Yeah, you can continue to talk. No?
Yes, yes. Please ask, sir. Please ask.
Yeah, I wanted to,
Dr. Singh, please ask
my
and
request to
let.
you to reanalyze data and find out the confounders. And you can also communicate with the experts who have already published the studies, but whether they have tried to find out these confounders, protective factors, because
Okay,
protective
okay.
factors can cause such alterations. And
Okay.
yes.
We didn't
Thank you.
found any, I mean, we didn't measure any protective factors. This is a wonderful idea. If we will put the protective factors also in our study, so that will enhance its, I mean, level of the study will go up, because the protective factors are important factors if we are doing circadian rhythm based studies,
Thank you.
along with the risk factor.
Thank you, Dr. Fatima. I think that you answer for question of Professor Singh.
Yes.
And I try again about Conticha Tanking. Are you here?
Yes, I'm here.
Oh, fantastic. Can you?
Hi.
Yeah.
Yeah.
Okay. So should I help you with the translation of presentation?
I can. Do you see my screen?
Yeah, we can, please.
Yeah.
Fantastic.
So I can.
Yeah, you can start, please.
Okay. Okay. So I guess it's in the morning in Russia, right? So good morning, everyone. My name is Chanisha Tankit. I am a cardiologist from Julapon Hospital in Bangkok, Thailand. So first of all, I have to say that I am very delighted to be presenting my research paper here in this international meeting today. So my research is about the effect of spironolactone in reducing ventricular arrhythmia with reference to circadian rhythms in ICD implanted patients. So we all know that implantable cardioverter defibrillators or ICDs has shown not only benefit in treating ventricular arrhythmia, but it does also significantly reduce mortalities in patients with severe LV dysfunctions, as we seen from a large RCT such as SCARCHEF, which shown that ICD reduced absolute risk of 7.2% at 5 years. However, despite these potential benefits, ICD therapeutic shocks can also reduce in many deleterious effects, such as psychological, heart failure hospitalizations, and even result in higher mortalities. There is evidence that in heart failure patients, there will be elevations of aldosterone level, which will lead to activations of many neurohormonal systems. A large RCT such as Epsilon and Wales showed us that by blockage of these aldosterone receptors, we can reduce mortalities and sudden cardiac death in heart failure patients. Previous basic science and animal models suggest that spironolactones have benefits in reducing ventricular arrhythmia incidence. However, there is still not enough evidence to confirm this hypothesis. That brings about our study, which is to study the effect of spironolactone in reducing ventricular arrhythmia occurrence and the number of ICD therapies, which could be either anti-tachycardia pacing or shock in ICD implanted patients, and also to identify risk factors contributing to ventricular arrhythmia, and also to find about spironolactone adverse effect. Primary outcome of our study is, first of all, ventricular arrhythmia episodes, which could be ventricular tachycardia or ventricular fibrillations, and number of ICD therapies, either ATP or shock. Secondary outcome is risk factors contributing to ventricular arrhythmia and spironolactone's adverse effects. Our inclusion criteria comprise of, firstly, LV dysfunction, which defined as LVEF less than 50%. The cause can be either ischemic or non-ischemic. Patients implanted with defibrillators, either ICD or CRTD. patients who have New York Functional Class 1 to 3. So the result from our studies, our study is a prospective cohort study. We include 110 patients who implanted with defibrillators, 40 patients in spironolactone groups, and 62 patients in control group. This table shows baseline characteristic of the patients in our studies. There is no statistically significant difference in baseline characteristic among both groups. Patients in control group has a little bit higher age when compared to control groups. However, there's no statistically significance. Majority of patients in our study are male genders. Roughly half of our patients have ischemic course, and the other half has non-ischemic cardiomyopathies. Only 1/3 have diabetes, and about half have hypertension. Majority of our patients have LV function less than 35, with means LVEF at 26 in treatment groups and 28 in control groups. For type of defibrillators, half of our patients was implanted with ICD and the other half with CRTD. Majority of our patients has functional class 2. Interestingly, patients in our trial were implanted with defibrillators due to primary preventions with rate of about 3/4. Only 1/4 was implanted due to secondary preventions. And surprisingly, patients in our trial are medication optimized with beta blocker prescribed at the rate of 100% in control group and 95% in, 100% in treatment group and 95% in control groups. Last blockage was prescribed in about 85% in spironolactone groups and 70% in control groups. For primary outcome, we found that patients in spironolactone groups have lower episodes of ventricular arrhythmia when compared to control group, with incident rate ratio of 0.65, statistically significant. When separate into type of ventricular arrhythmia, majority of our patients has non-sustained VT. Patients in spironolactone group has lower episode of both non-sustained VT and VT, with incident rate ratio of 0.66 and 0.36 respectively. We didn't find any ventricular fibrillation episodes in our trial. When we come to the total therapies, we actually found no statistically significance in ICD therapy. However, there's trends toward lower incident of therapy in spironolactone groups with the incident rate ratio of 0.55. And most of the therapy we found is anti-tachycardic pacing. We observed only 3 shocks in the whole period of 6 months. And interestingly, all the shocks occur in the early morning. For the secondary outcome, we found that poor LV function, LVEF less than 35%, was a robust risk factors for ventricular arrhythmia, with incident rate ratios of about 13. Age more than 60 years old, male gender, diabetes, hypertension were also a risk factors for ventricular arrhythmia events. For the adverse effects, we found only 1 patient who received spironolactones and have breast tenderness, which improved after that discontinuations. And there is no other adverse effect found in our studies. These figures show the relationship of each factors and ventricular arrhythmia events. LVE function less than 35% is a very robust risk factors for developing ventricular arrhythmia. Male gender, age more than 60, diabetes, hypertension are also a robust risk factors. Discussion. So results from our trial proved our hypothesis that spironolactone could significantly reduce ventricular arrhythmia events among patients who implanted with ICD and have LV dysfunction after median follow-up period of 6 months. Patients who took spironolactones have a significantly lower incidence of total ventricular arrhythmia episodes, non-sustained VT and VT. Spironolactones was a strong protective factor for ventricular arrhythmia events with incidence rate ratio of 0.41. Most of ventricular arrhythmia events in our patients were self-terminated and requiring no therapies. The non-significant result in total therapies in our study may be explained by, firstly, majority of total episodes were non-sustained VT, which the sophisticated ICD programming decreased the inappropriate therapy, hence lowered the therapy in both groups. Secondly, patients were relatively younger and had lower coronary heart disease when compared to previous studies. We suspect that the natural history of DCM was relatively benign. Thirdly, medical therapy in our patients were more optimized according to the current guidelines, with almost 100% usage of beta blockers. The anti-arrhythmic effect of beta blockers was well established and might attribute to the low incidence and non-significant results of the therapies. And lastly, majority of our patients were implanted due to primary prevention. And when we investigated into the shock episodes, our patients who have ICD shocks, the event actually happened in the early morning. This could indicate an increased circadian occurrence of arrhythmia in the morning. There is evidence from previous trial that there is a circadian rhythm in cardiac pacemaking and other electrophysiological functions of the heart. Apart from this, there is a circadian rhythm in other arrhythmics, such as bradyarrhythmia and supraventricular arrhythmia, which actually occur in the morning. The possible underlying mechanism of this are a central circadian clock in the suprachiasmatic nucleus in the hypothalamus, which may then likely affect the electrophysiology of the heart and arrhythmogenesis. This is possible via various neurohormonal factors, particularly the autonomic nervous system, and a local circadian clock in the myocardial cells. The myocardial circadian clock may drive a circadian rhythm in the expressions of ion channels in the heart, which in turn vary arrhythmic substates. Spironolactone may improve the concentrations of intracellular potassium and magnesium in the cardiac cells, leading to improvement in the circadian clock function with better response to anti-arrhythmic treatment. Conclusions: in ICD implanted patients with LV dysfunctions, spironolactone could be a protective factor which significantly reduce ventricular arrhythmia events. Spironolactone treatment also have a trend toward lower therapy events. Risk factors for ventricular arrhythmia events are LV function less than 35, male gender, elderly, diabetes, and hypertension. An increase in circadian occurrence of arrhythmia in the morning has been observed in our trial. Thank you. Okay.
Thank you, dear Professor Tanking, because
Yeah.
especially thank you for spasibo in Russian language. Especially.
I try to find that.
Yeah, from us. And it was a very interesting presentation, especially maybe for me, because it's about some pharmacological aspects of treatment. And I am pharmacologist, so for me it was yes,
Yeah.
it was very interesting, and I think we hope we will be keep in touch and to continue your research.
Okay.
And dear colleagues, do you have some questions to our lecturer? No, I think that is it.
Okay.
It will be fully aspect.
Okay.
So okay. So now our next lecturer is Anna Brick. Are you here, Anna?
Yes, good morning, I'm here.
Perfect. Okay, please, Anna, you can share your presentation with us, and yeah, ready to hear you.
Yes, so just a second, because I was not, I didn't think that it was my turn. So just a second.
Okay, we are waiting, and let me check our next lecturer too. 1 minute. I ask
Hello.
Chakravorty. Are you here? Okay, it's our next. Okay, please, Anna. Yes.
Yeah, you can see my screen.
Yes, we can.
Okay, good morning, everyone. I want to introduce you my issue that sounds like features of the circadian profile of blood pressure and heart rate under monochromatic lightening in the spontaneously hypertensive. It's our work that we did at our university, People Friendship University of Russia, Institute of Medicine, and our department that calls the VIPO Department of General Pathology and Pathophysiological Physiology. So, as it was found, the third type of photoreceptors, the mammalian retina, called internal photosensitive internal ganglion cells, the IPRG. These photosensitive receptors regulate many biological and behavioral processes, including the secretion of melatonin and cortisol, alertness, EEG reads. These photoreceptors have neural connection with the suprachiasmatic nucleus or the hypothalamus, which substantially synchronize the peripheral clock, which is other, and in this way synchronize the whole circadian system with the geophysical time. Maximal sensitive of IPRG is in the shortwave region of the spectrum. Peak sensitive is about 460 nanometers. Recently, there has also been widespread use of devices with LSD screens and energy stemming from LEDs, which are sources of visible light with a predominance of the short wave length part of the spectrum in the daytime, I mean evening and night. Our objects, as a part of the project, we studied the features of biological width of the cardiovascular system in essential hypertension under exposure to monochromatic light with a wavelength 480 nanometers. The experiment was performed on male SHR rats with spontaneously hypertensive rats, and with respiratory rats is our control group. We modeled the two life patterns. The first, it was standard life pattern, 12 hours light and 12 hours darkness. And the second, it was 12 hours light and 12 hours darkness.
Anya, Ань, очень плохо слышно, вообще невозможно просто. Что-то у вас со звуком невозможно понять, что вы говорите.
Так, может быть, это просто мое страшное произношение? Или
Нет,
прям
нет,
плохо?
нет, нет, это не с произношением проблемы, это именно какая-то помеха или что-то еще, просто невозможно вот и слушать. Ну, невозможно понять, да, какие-то шумовые какие-то эффекты, может быть, есть возможность, или вообще там отключить гарнитуру, поговорить через ноутбук, или как-то...
Так вот, проблема в том, что я как раз-таки через ноутбук разговариваю, может, наоборот, подключить наушники, и будет лучше слышно через гарнитуру.
Да, может лучше тогда через гарнитуру, потому что звук
Да,
вообще не
да.
идентифицируемый, просто какой-то идет.
Да, шумовой какой-то эффект невозможно слушать. Excuse me, dear friends, we will just try to improve sound. Получается, Ань?
Слышно ли вообще меня теперь?
Слышно, но тоже какая-то вот помеха, какой-то шумовой постоянный эффект.
Можно это шумит?
Нет, так вообще не слышно, кошмар какой-то. Совсем.
Никак.
У вас нет никакой альтернативной версии, там как-нибудь по-другому подключиться? Я могла бы просто дать время, мы могли бы в конце концов попозже послушать доклад, потому что так невозможно воспринимать на слух.
Я могу...
Да, там вообще звук практически просто шум идет какой-то. Аня, а вот когда вы занятия проводите, там же все нормально?
Да, но занятия-то мы через Teams проводим.
А вот так то же самое, все те же технические средства используете?
Да, обычно сижу через ноутбук,
Ну, ничего себе.
и обычно меня хорошо слышно.
Может быть, вы еще раз переподключитесь, мы подождем в конце концов, потому что это бессмысленно просто слушать, это мимо все проходит.
Давайте я тогда сейчас попробую не через приложение Zoom, а через браузер просто подключить.
Да, попробуйте через браузер, может, так
Спасибо.
будет лучше.
Dear colleagues, please, some technical problem. Let us to reconnection our Anna, and after we will try to make it better. Please wait a little. If somebody has some questions, you can send it me in chat. We will try to answer. Our conference coming to finish. Some just 2 lecturers, and after. Yes, I'm ready. Yes, I think we can. Yes, please. You can start. If you want, I can share your presentation.
Yeah, I've already sent you.
Yes, I will open now. 1 minute.
Yeah. Okay.
1 minute.
Нет?
Так.
Dr. Saibal, can you tell her the time of sending? When did you send?
Just 5 minutes back.
Oh, good.
Yeah, I will try to open.
Yeah, I got it.
Perfect.
That's fine.
Yeah, 1 minute. Okay. Please, I'm ready, so you can.
Yeah, you want me to start?
So sorry. 1 minute. Yeah, you can. Please, doctor.
Okay.
Mhm.
Good afternoon, everybody. I welcome you all to this last part of the CME. I am from India. I am Dr. Chakravarti, specializing in diabetology and critical care. Today, please proceed. How can I proceed a slide? Yeah. So today I'll be dealing with one of the most common disease around the world. Prevalence of this type 1 and type 2 diabetes is ever increasing, and it is projected to increase to 693 million adults worldwide by 2045. And among them, type 2 diabetes makes up approximately 95% of all diabetes cases. So whatever we are dealing with, the topic today is mostly concerned with the type 2 diabetes, which is a lifestyle related disease. The high and increasing prevalence of type 2 diabetes may be explained in part by lifestyle risk factors, such as physical inactivity, smoking, and poor diet. In the recent decades, an additional lifestyle risk factor that has become common in modern society is the circadian rhythm disruption. Approximately 20% of all individuals are involved in shift work, and 33% sleep no more than 6 hours per night, and 69% experience social jet lag, which is slightly different from the usual jet lag what we know. The shift work has been associated with 10 to 40% increase in the risk of diabetes. Next slide, please. Next slide, please. So the impact of this circadian disruption on the glucose control in healthy individuals as well as in those patients with type 2 diabetes. The individuals exposed to the shift work have been noted to have a 9% increase in the diabetes compared with the individuals with no shift work experience. The risk is also positively associated with duration of exposure of shift work, with a 5% increase in risk for every 5 years of shift work. So the disruption increases the risk of type 2 diabetes in a dose-dependent manner. So two things develop in such cases. One, a patient who is already diabetic and patient who is healthy. Those who are healthy, they are at more risk of developing diabetes. Those who are having pre-diabetes, they are at a risk of transition into the frank diabetes. And those who are diabetic, they will have a preference, the uncontrolled, and maybe a high HbA1c is noted. Next slide, please. So another prevalent circadian disruption is a social jet lag, which is quantified as sleep and wake timing discrepancies between the work and the free days, as an estimate of misalignment between the biological time and the social time. As it has been reported that the people with social jet lag of greater than 1 hour, approximately 69% of the population have 1.75 times the prevalence of diabetes. Next slide, please. So that these diabetic individuals working in night shifts present with higher HbA1c level than those not working the night shifts. This is what is important. Irrespective of rotating or non-rotating shifts, and after adjusting for age, BMI, insulin use, sleep duration, morning and evening preference, and percentage daily carbohydrate intake. That means irrespective of all these confounding factors, still it has been seen that those who are working in night shifts have a higher HbA1c level compared to those who are not working in night shifts. Next slide, please. So I would like to say a few words about certain terminology which are important whenever whenever these chronobiology terms are used, there are certain experimental protocol which has been used in these patients who are actually tested for this shift work and the work and this time difference. So there are two protocols. One is a constant routine protocol in which the participants are kept in a semi-recumbent posture and given isoenergic snacks at regular intervals during extended wakeful in time-free dim light environment, which is not natural, designed to remove the 24-hour cycling in all environmental and behavioral inputs, thus enabling measurement of circadian rhythms independent from these masking effects. Next, please. So one is a constant routine protocol. Next slide, please. And the second one is a forced dysynchrony. So in this, in which participants are studied in time-free conditions under dim light during a recurrent short or long sleep-wake cycle, including the fasting, feeding, or rest activity and the postural cycles of the same period. So it disentangles the effect of the circadian rhythm from the effects of behavioral and environmental changes. So all those confounding factors which are coming in between, they are usually taken off and allow the measurement of biological process in response to behavioral environmental cycles across the circadian phases. And during the investigation, then we see for the alignment and misalignment in this. Next slide, please. And this, we usually checking this misalignment, which is the incorrect timing of the rhythm in relation to the rhythm period cycle length, or the time it takes cycle from one circadian phase to the same phase again. Next slide, please. So this is, so here what we are seeing that we have two clocks. One is an environmental, which is a central clock, and the other one is a peripheral clock. In central clock, which is located in the suprachiasmatic nucleus, and the figure on the right hand side, as you can see here, it is well aligned. So here the feeding exactly at time 8 o'clock, 4 o'clock, 12, and here the alignment is changed, misalignment. So that means the suprachiasmatic nucleus and the peripheral clocks, there is a misalignment between these two. As you can see, the peripheral clocks are also located in the pineal, in the adrenal, muscle, liver, pancreas, and GI tract. So once it is misaligned, you can see the curves going like this. Next slide, please. So here, the central clock in the SCN, the misalignment can occur from various sources. One, it is environment or a behavioral misalignment. There can be peripheral clocks misalignment, and all these are partially regulated through genes which are there in our peripheral tissues. Next slide, please. Next slide, please. These are the various way it is done. So from the liver, then it goes straight to suprachiasmatic nucleus. Next slide, please, with various types of neurons like GABAergic neuron or glutaminergic neuron, orexin, and these are the various neurons which are the pathways. Next slide, please. And there is, next slide, please. And there's an interplay of various genes, BMAL genes, which is very important in this. Next slide, please. Next slide, please. So this, if we define what is circadian rhythm and its disruption, the previous slide, please. Previous slide, please. No. Go back, please. No, please go back. Please go back. Please go back. No, not this right. Please go back. One more. One more. Right, okay. So these endogenous circadian rhythms are produced by the multi-oscillator system composed of the central clock located in the hypothalamic suprachiasmatic nucleus and as well as in the peripheral clock, which is there in every organ. And this molecular clock mechanism is comprised of feedback loops with the main transcription translation negative feedback loop involving clock core genes and BMAL genes also, and there are several others like PER and CRY. This SCN is entrained primarily by the light signals via retinohypothalamic tract and through neural, thermal, and hormonal pathways. The SCN relays the timing signals to other brain areas and the peripheral organs such as pineal gland, adrenal, liver, pancreas, muscles, adipose tissue, and GI tract. Next slide, please. So this circadian misalignment can occur between the central clock and the environmental, like light, dark, environmental misalignment, or behavioral misalignment, like feeding, fasting, or wake, sleep, or activity rest. These are behavioral misalignment. So misalignment can occur as a result of environmental reasons or behavioral reasons, or between the central clock and peripheral clock throughout the body, what is known as internal misalignment. So three types of misalignments are commonly seen. One is environmental, second is behavioral, and third is an internal misalignment. Next slide, please. So we can test this glycemic control in various ways: hyperglycemic clamp, hyperinsulinemic euglycemic clamp, IVGTT, mixed meal tolerance test, and ODs. All these has been used in various studies, which has randomized controlled trials also. In various studies, these are the various methods which has been used to check for the glycemic control, the timings, the circadian rhythm. Next slide, please. So let us now see what exactly is happening during this sleep-wake cycle. If you see the A, there is a modern alignment. This is the way we are normally going. So we have a sunlight, which is day, night, and a small bit of sunlight is also there after night. And then artificial light. This is the artificial light, and this is a dark phase. The endogenous clock, it works as a circadian day and circadian night. So what happens to the melatonin? It goes down during the wake period when we are taking the meals, and then during the sleep, it goes high up. And when there is a misalignment which occurs, what exactly happens? Then this sleep phase becomes early. First is the dark and then light phase. And during this, the melatonin goes down. So there is a complete reversal of the melatonin secretion. The misalignment during the jet lag is also similar. Here also the sleep during the melatonin goes down because this is during the daytime of modern alignment. So this is just the reverse of what is going on. Next slide, please. So here also, this misalignment between the central clock and the behavioral or environmental cycle on the glucose tolerance. These are the various ways I mentioned, whether it is a forced dysynchrony. These are the ways, or a rapid misalignment. As you can see, the misaligned, the glucose is going high, and the glucose is high time since meal, as has been mentioned, with rapid misalignment also and gradual misalignment also. And the insulin level, it is slightly lower here when misaligned, and this is a quite erratic secretion, as you can see. So during the wake time, during the sleep time, when it is misaligned, the melatonin level goes down, and during the wake time, it was already on the higher side, so it was on the higher side. Using this test meal in the morning breakfast, or it is test meal has been, once it is misaligned, maybe it has been given in the afternoon or evening time. Next slide, please. So what exactly are when we find this, there is a misalignment, what is this happening? What is the impact and behavioral influence on this glycemic control and potential transition to diabetes? So three things happen. One is an impaired glucose tolerance develops, which is secondary to either impaired beta cell function or impaired insulin sensitivity. The impaired glucose tolerance can develop either through circadian evening or circadian misalignment. Maybe there is substantial sleep restriction, a recent circadian misalignment plus sleep restriction, or a behavioral change. The impaired beta cell function occurred during circadian evening and recent circadian misalignment and sleep restriction, and impaired insulin sensitivity occurred during circadian misalignment, sleep restriction. So the difference between these two, that impaired beta cell function occurs during evening time. This is the circadian evening time when the impaired beta cell function occurs. Next slide, please. So these components, now it has been tabulated. If you see that the circadian evening, the beta cell function goes down and glucose tolerance also goes down. In the behavioral evening, there is some decrease in insulin sensitivity. In circadian misalignment, there is a decrease in insulin sensitivity. In sleep restriction, there is a decrease in insulin sensitivity. And here, the beta cell function does not go down. This is what is important. So in circadian evening, beta cell function goes down. In other types of misalignments, sleep restriction, behavioral, or the circadian, it is the insulin sensitivity which goes down. Of course, all of these finally relate to poor or lowering of glucose tolerance. Next slide, please. So we have seen now how the glucose tolerance varies with time and what are the various mechanisms. This circadian disruption impairs beta cell function and insulin sensitivity, resulting in impaired glucose tolerance. These circadian disruptions acutely impact the glycemic control and thereby may increase the risk of impaired glucose tolerance and transition to diabetes. These healthy individuals, as well as those with type 2 diabetes, may support this glycemic control. How this glycemic control is maintained? It is through a proper alignment of the endogenous, behavioral, and environmental rhythm. All three things working in unison will only give you a good glycemic control. Any disturbance or misalignment leads to disturbance in the glucose homeostasis. I thank you very much for your kind listening.
Thank you, Professor Chakravorty, for your interesting presentation. Dear colleagues, do you have some questions to our lecturer?
I have one question.
Yeah, please.
I'm Alexey Inyushkin. You mentioned, dear Dr. Chakravorty, you mentioned that the social jet lag, more than 1 hour, may be a factor of risk for diabetes. My question is, what's the best way to measure this social jet lag in hours? How to do that?
So it is a difficult job. Now you have two protocols here. I mentioned two protocols. One is a dysynchrony protocol, and the other one is that constant protocol. These are the protocols which has been used mostly to find out, to distinguish how the insulin is being secreted, how the sugar is, and this control is there or not. So these two protocols are commonly used for diagnosing and this delay, because you need to create an environment of the same social jet lag, then only you can do it.
Mm-hmm. Okay, thank you very much.
Dr. Chakravorty, I enjoyed your talk very much.
Yes,
I'm Dr. Singh. Perhaps jet lag may be associated with decreased melatonin and increased cortisol. So these, but they are not constant. So this could be done. But my question about, you have not shown any cohort studies showing repeated attacks of hypoglycemia, which are associated with greater morbidity and mortality in diabetes. So blood glucose variations in the form of repeated hypoglycemia can cause marked changes in the complications of diabetes.
Right.
Can you
So
comment
here
on that?
two things. Yeah, here two things are seen. One is a social jet lag and other is jet lag. So one of them is a chronic process. Social jet lag do not occur and so fast, and this chronic acute jet lag is a rapid misalignment. There is a difference between these two. It's a chronic misalignment, and there is acute in jet lag. There is an acute misalignment. So what is exactly happening? All these hormonal changes, they occur faster in this acute disalignment and a little bit slower. Now, there are definite cohort studies, but I have not read all those. But definitely there are cohort studies comparing your social jet lag to the rapid jet lag which develops after a flight.
Thank you very much. Dr. Yulia.
Yeah,
Hello.
Please.
Professor Yulia.
Please wait.
After
Dr. Singh, please wait a little.
Please give 5 minutes.
Please. Dr. Chakravorty, please. I see the question in our chat. Can you read the chat or should I read it?
Yeah, let me see.
Yeah, please.
Yeah, okay. Yeah, the question here is that how can we remedy or prevent the effects of social jet lag on our organs and health? Definitely, we can do that, but this is all in the research stage. That is one. Second, the behavioral changes are definitely required. It has been mentioned in various studies, the behavioral changes, maintaining and spreading the awareness of proper timing of meals, exercise, all these are important. Coming to the medicine part, supplementation of melatonin as and when required can be tried, but it is a short-term measure. So a long-term measure involves your social awareness about your disease.
Okay.
Yeah, okay.
Yeah, thank you for your answer. Colleagues, do you have some other questions, please? No, I think not now, but anyway, you can send it in our chat. And I think the Professor Chakravorty can look at later. Yes? Okay. Thank you. Thank you, dear Prof. Yes.
Thank you very much.
And Anna, are you ready?
Yes, I'm ready. Do you hear me?
Oh, yeah, it's a perfect sound now. So please start it.
Okay, I have one question for you, Yulia Shamilovna. I need to start at the first slide, or I can
Yes,
continue.
it's better to restart, Anna.
Okay. Can you see my presentation?
Yes, we can.
Perfect. Okay, good afternoon for everyone. Sorry me for my technology problems. I don't expect it. My issue about features of the circadian profile of blood pressure and heart rate under monoclimatic lighting in spontaneously hypertensive rats. We did our issue at our university, People Friendship University of Russia, Institute of Medicine, Department VA Frolov of General Pathology and Pathophysiology. As it was found, the third type of photoreceptors in the mammalian retina, called internal photosensitive internal ganglion cells of the retina, IPRGEs. It regulates many biological and behavioral processes, including the secretion of melatonin and cortisol, alertness, and EEG reads. These photoreceptors have neural connection with the suprachiasmatic nucleus of the hypothalamus, which subsequently synchronize the peripheral clock with each other, and in this way synchronize the whole circadian system with the geophysical time. Maximal sensitive of IPRG is in the shortwave blue region of the spectrum. Peak sensitive is about 460 nanometers. And recently, there has also been a widespread use of devices with LCD screens and energy-saving lights, which are sources of visible light with a predominance of the short wavelength part of the spectrum in the dark time, and I mean evening and night. As a part of the project, we studied the features of the biological rhythm of the cardiovascular system in essential hypertension under exposure to monochromatic light with a wavelength 480 nanometers. The experiment was performed on male SHR rats, it's spontaneously hypertensive rats, and Wister-Kyoto rats, it's our control group. Two light patterns were modeled at 12 hours light and 12 hours darkness. It's standard light pattern, and 12 hours light, 12 hours darkness with the visible spectrum of light in the 480 nanometers regions. We called it monochromatic lighting pattern. To assess the levels of blood pressure, BP, and heart rate, HR, continuous 24 hours registration of these indices was carried out by the method of telemetric monitoring using the equipment Data Science International. The obtained data were processed using the computer programs DataQuest RT 4.2 and ChronosFit. For all indicators, the following values were determined by the method of linear analysis: mean 24 hours values, daytime and nighttime values of systolic blood pressure, diastolic blood pressure, and heart rate. So our results. The most significant changes were characteristic of spontaneously hypertensive rats in relation to heart rate. They are characterized by a significant decrease in heart rate determined in each time period, while the prevalence of nighttime values over daytime levels remains despite the changes of a light pattern. For Wister-Kyoto rats, there are no significant changes in monochromatic lightening compared to standard light pattern. However, for normotensive and hypertensive rats, a significant predominance of the mean nighttime values of heart rate over mean daytime values is typical under both the light patterns. So monochromatic lightening with a blue spectrum during daytime hours has no effect on the chronostructure of heart rate under normal and elevated blood pressure. Under monochromatic lightening, in comparison with the standard light pattern, the tendency to a decrease in systolic blood pressure in the daytime is seen in Wister-Kyoto rats. At the same time, the difference in the systolic blood pressure at night and for 24 hours period is significant. Regarding this indicator in SHR rats, only a similar trend is observed. However, there is no significant difference. The rats of Wister-Kyoto and spontaneously hypertensive rats strains are characterized by the absence of significant difference between the mean daytime and mean nighttime values of both systolic and diastolic blood pressure under standard light conditions. Under the monochromatic lightening, SHR rats present a circadian rhythm of diastolic blood pressure, which is manifested as an increase in the level of diastolic BP at night. So we can sound our conclusion that monochromatic lightening seems to restore the circadian structure of diastolic blood pressure in SHR rats due to an increase in the nighttime values. So it's the end of my presentation. Thank you for your attention and for your waiting for my presentation. Maybe it was very fast, but maybe somebody have questions for me.
Of course, Dr. Anna. Dear colleagues, do you have questions to our speaker?
Can I ask?
Yes, of course, Prof. Anushkin.
Alexei Inyushkin again.
Yeah, please.
It's interesting talk, and I would like to ask you, what's the mechanism or proposed mechanism behind this effect of the monochromic lighting?
Maybe it will be better if I answer in Russia, because I understand that Alexei Inyushkin is to Russia, or I need to answer in English.
No, it's better to answer in English because the rest of participants may not understand you.
Okay, I will try. We think that mechanism of this function is that melatonin, its secretion is depend on the light pattern from the lightning in our day, and the maximum sensitive of the photosensitive reception is shortwave blue region of the spectrum. So we try to use this spectrum of light and see like how it's depend on melatonin secretion and how it regulate cardiovascular system.
Professor Inyushkin, are you satisfied with the answer?
Sorry, the microphone switched off.
Okay.
I mean, that's okay, but this 480 nanometer, right? This is included in visible spectra of lightning. So what's the mechanism? The other parts of the spectrum is absent here.
Yes, we have only one spectrum, only 480 nanometers, and other spectrum of the visible light was stopped.
Yeah.
So it was monochromatic lighting.
Perhaps that is the point, not your, monochromic lightning, but absence of other part of the spectrum. What do you think?
If you can explain that was absence of monochromatic, so you tried to say me that we have another spectrum of light, or somebody or someone else.
Okay, I would think still about that. Thank you very much anyway.
You can chat me and I will try to answer you maybe in chat.
Okay, that's okay. Yeah, thanks.
I have a question, Dr.
Yes,
Anna.
yes, Fatima, yeah.
Yeah, which monochromatic light color have you used?
Which monochromatic
color is a color scheme that is composed of variation of one color. Which color have you used in monochromatic light?
We use blue color.
Okay, thank you.
Thank you for your questions. Some other questions do you have? No. Okay. Thank you, Dr. Anna, for your presentation. As we see, it was our last speaker for today with presentation. But in conclusion of our conference, I want to ask if somebody wants to tell something to us about this conference, about this, I don't know, emotions that they have. So we will be glad to hear.
Thank you, Professor Yulia. I'm Dr. Singh from India. Since I have been coordinating with you,
Yes.
first of all, I would request Professor Cornelissen to make some comments for 1 or 2 minutes, and then perhaps Professor Wilson, and then Professor Salad, and then Chibiso. So may I request Professor Cornelissen to say a few words?
We can try, but I tried to send the message to Professor Cornelissen. I'm afraid that in USA it's too late. So we can ask, of course, but if she can't, so we will be just grateful for all your time that she spent here.
Dr. Wilson, are you there? Dr. Shalet? So all are good.
I am here.
Oh, good. Please speak.
Okay, so I'd like to thank again the organizing committee for organizing such a nice conference. It was very nice to participate in this meeting. And also I would like to...
Our shortcomings, how we can improve.
I'd like to send you my best wishes for good
Something
health
about
to all of you and your relatives.
Right.
Bye-bye.
Thank you, Prof. Shalaya.
I'd like to say if I may, Julia.
Yes, I will be glad. Yes, please. Everyone, you can speak. Yeah, of course.
Dr. Verma, are you there?
Please,
Dr. Verma,
Professor Singh, please, Professor Singh, wait a minute. But first, Ms. Aminat wants to tell some words to us. And after we will ask everyone who wants to speak something. Please, Dr. Aminat.
Very good.
Do you know, I thought yesterday what I was doing at the conference where mostly medical scientists participate. Last year at the 23rd conference or Congress on clinical nutrition, I spoke about the importance of not only what we eat, but also how and when we do it. Dr. Singh spoke on this subject the day before yesterday. Recently, I discussed with Professor Said Begov of University of La Sapienza about the possibility of conducting joint research on the peculiarity of the state of spinal health in practicing Muslims and those who do not follow the instructions. And Professor Manal Muhammad discusses the role of prayer and meditation for health. I think interdisciplinarity is probably the right way to go. And the second thing I would like to say, what do you think, what did I do last night? I remember that melatonin is produced in the complete absence of light and carefully closed the curtain in the rooms of my children and my husband. I explained to my children that the production of melatonin begins at 21 and it's better to do exercise at 8 in the morning. We recently conducted a study of behavioral health factors of school children in Moscow, Dagestan, and Tumen, and found that about 70% of teenagers everywhere do not think about the thoroughness of mastication. About half of Moscow school children go to bed after 24 o'clock. And a lot of other problems were found out in the field of behavioral factors that worsen health. We have less than 10% of healthy children by the end of the school. So I think it's important to bring the results of scientists' research in an accessible form to children, their parents, teacher, first of all. And since the rapid deterioration of health in Russia begins, as we found out from school age, it can be in the form of guidelines or lifestyle instructions. We have a little problem with that in Russia. Policy may sometimes differ from the existing problems that they are designed to address. And the third thing I would like to say, to note the importance of multi-level participation in such conference. In the summer, we held a scientific and practical seminar, which was attended by school children, finalists of the International Competition of Project and Applied Research, students, and frame of scientists. It was an amazing experience. Dr. Singh, you are not only a great scientist, you are a great organizer and engine of science. Thank you very much.
Thank you very much. But before the meeting is adjourned, I would like to say my acknowledgements to Professor Yulia, Gustina Yulia, Professor Sergey Chibiso, and Professor Omar Bavarit, who have given me an opportunity to coordinate this meeting and to serve the experts all over the world. I hope we would continue our cooperation, and I would request all of you, all the experts who have delivered their talk, to send their brief papers, those who have not sent yet, to me immediately. And you can also send to Professor Yulia or Professor Omar. Thank you very much indeed, and bye-bye.
No, it's not end. So I think that now we can hear Professor Sergey Chibisov. I will try to translate. So of course, I'm not a professional translator, but if you let me, yes, because it's our leader and our scientific tutor, куратор. So please, Сергей Михайлович, давайте предложение за предложением, хорошо?
Хорошо. Уважаемые коллеги и друзья,
Dear colleagues and friends,
мы завершили научно-практическую конференцию «Хронобиология в медицине и спорте».
We are closing the scientific and practical conference Chronobiology in Medicine and Sport,
которую проводил Медицинский институт Российского университета дружбы народов в столице России, Москве.
which was held by the RUDN University Medical Institute in our capital of Russia, Moscow.
Считаю, что мы сделали хороший подарок ко дню рождения Франца Халберга.
I think we made a good birthday present for Franz Halberg,
нашего учителя и наставника.
our teacher and mentor.
На конференции обсуждались вопросы практической хрономедицины.
The conference discussed questions of practical chronomedicine.
Это мы услышали в первом докладе Жермен Корнелисен и ее коллег из Центра хронобиологии Франца Халберга Университета Миннесоты.
We heard this in the first lecture of German Cornelissen and her colleagues from the Halberg Center for Chronobiology, University of Minnesota.
Хорошо была представлена тематика хронобиологии в спорте в работах Юлии Корягиной и Анастасии Башкиревой.
The topic of chronobiology in sport was well represented in the works of Yulia Koryagina and Anastasia Bashkireva.
Очень интересные научные доклады мы услышали от профессоров Верма, Индия.
We have heard very interesting scientific reports from Professor Verma, India,
Шале, Франция, Благонравов, Россия, Сингх, Индия и Нюшин, Россия.
Professor Chalet from France, Professor Blagonravov from Russia, Professor Singh from India, and Professor Inyushkin from Russia.
Целью конференции было знакомство с современной хронобиологией различных процессов.
The purpose of the conference was to get acquaintance with the modern chronobiology of various processes.
Искренне поблагодарим Рам Бахадура Симха за активное участие в организации.
Yeah, we want to tell big thank you to the Professor Singh for his activity and participants.
Спасибо всем докладчикам и участникам конференции.
Thanks to all the speakers and participants of the conference too.
Спасибо студентам, которые проявили живой интерес к этой суперсовременной междисциплинарной науке.
And a special thanks to the students who showed a keen interest to this ultra-modern interdisciplinary science.
До скорых встреч. Председатель Общества хронобиологов России, председатель оргкомитета конференции профессор Чибисов.
See you soon. The leader of chronobiology in Russia, the chairman of this conference, Professor Chibisov. Спасибо, Сергей Михайлович. Спасибо. And maybe somebody wants to tell something, just 2 words.
Hello.
Hello, yes, please.
I just want to say thank you for being invited. I've gained quite a lot from the presentations, and I'm really glad I had the privilege to be there. It was also good to be able to see some of the former colleagues I met in Russia last year. Thank you.
Sir, what's your name? Sir, what's your name?
Nwazo Sarah.
Okay.
Dr. Nwazo Sarah from Nigeria.
Okay. Oh, Sarah.
He was in the Makhachkala with us, Dr. Singh.
Very
Yes,
silent.
Yes.
Very silent.
Very nice, very nice. Okay, and I want to tell some words to Professor Blagonravov, because he's a head of department and he's a scientific leader of this scientific area in our university. Please, Mikhail Lvovich.
Thank you very much, Yulia Shamilevna. Dear colleagues, I'd like to tell just a few words to conclude. It has been a great pleasure to take part in this conference, the conference which was held and organized at a very high level. And first of all, I would like to thank all the participants for their brilliant presentations. All of them were very, very interesting, and we have a good opportunity to exchange our opinions, to gain some more knowledge. It is it has been very, very interesting. And I would like to tell particular thanks to our organizing committee, to Dr. Guchina Yulia Shamilevna, to Professor Chibisov, to Dr. Amar and Professor Singh, because it has been especially difficult to hold this conference, to organize this conference in the conditions of pandemic. But I think I'm convinced that the conference has been organized at a very high level. And I would say that if Professor Hallberg could see it, he would be happy. I'm just convinced. So as Professor Chibisov said, it would be a very good present gift to Professor Hallberg for his 100th anniversary of his birth. And he could see that his ideas are alive. This is the most important thing. His ideas are alive and his ideas are developing. And I think that in some time we would have an opportunity to meet each other at some place, maybe at our university or at some other university, and continue our exchange of opinions and so on. Thank you very much, dear colleagues. Thank you very much, our organizing committee, for this brilliant opportunity to everyone to take part in this conference.
Thank you.
Thank you, dear Prof. Blagonravov. Thank you for your support, of course, and for these good words for us.
My pleasure, my pleasure.
Okay, so if it's all, so if no one who wants to tell something.
Hi, Dr. Yulia.
Yes, please. Yes, please, Prof.
I'm so happy that it was a wonderful conference, and I'm very thankful to all the organizers, to you, to all the organizers of this conference, especially my mentor, Professor R.B. Singh, for inviting me for this lecture. See, the time is very important because for everything there is a time on this earth, a time to born, a time to die, a time to plant, and a time to pluck what is planted, a time for sleep and a time to wake. God has made everything beautiful in its time. So time is really very important in medicine also. So it was a wonderful conference with all the beautiful and wonderful lectures. And I'll be thankful to the organizers of this conference if you'll also share the slides of the presenters, because it will also help the students for their start of work in chronobiological field. So it's my humble request to the organizers of this event to please ask the presenters to share their slides. That would be good for our students to start up their preliminary work in chronobiology. By this note, I end up and I'm very thankful to you, Dr. Yulia. You were so, tirelessly you were working since 3 days. And it's really wonderful to meet all of you through this virtual conference indeed. Maybe next year we will meet in real, not in
Yeah, of
virtual.
course. I hope for this. Yes.
So I would really thank you, all, thank to all the organizers of this event. And as chronobiology is my field, so I enjoyed each and every lecture over here. And with this note, I end up. Thank you so much, each and every one of you. It was very glad to see you virtually. Maybe we'll meet next year or whenever this conference will occur the next time. Thank you so much.
Thank you. Thank you for your good words. And indeed, it's for me, it's pleasure to work with scientific researchers from all over the world. Yes, it's true. And of course, thank you to Professor Singh, and thank you for all for supporting, because of course, without you, every one of you, it was not possible. So thank you for everyone who preparing, like I see now, yes, the Professor Sigelova, yes, thank you so much. Thank you so much, friends. And I hope we will see each other. It's not so important distantly or maybe in a real life, but I hope now we will collaborate together. Thank you.
Thank you.
Thank you. Thank you.
Bye, dear
Bye,
friends.
everyone.
Bye.
Bye.
Thank you. Bye-bye.
Thank you very much for all. And I want to meet you again and hear your wonderful, interesting reports. Thank you, Sergei Mikhailovich. Thank you.
Thank you, dear.
Thank you, Professor Singh. It's excellent for us. It's
I will come
greatest
and meet you.
conference. Thank you very much.
I'll come and meet you in Rajasthan and
Thank you.
Moscow both.
I hope we meet and see see or all of us, not only in distance, but we can see from eye to eye.
Yes, yes. Next time we'll meet eye
Be
to eye.
healthy, be healthy. Now it's difficult situation with pandemic COVID-19, and I wish you for all health.
Thank you, Anastasia.
Thank you, Dr. Jeremilia. Thank you so much, Dr. Yulia. Everyone, bye from her side. Bye.
Bye. Thank you, dear Prof. Saket. Yeah.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you. Thank you.
Bye-bye.
Bye-bye, dear.
Bye.
Bye.
Sarah, I'm waiting.
Oh, I'm coming.
Where are you? I can't see you.
I'm coming. Let me join the Zoom. Okay, I've turned on the video.
Oh, I see you now. Hello.
How are you?
Oh my.
How are you?
Boy.
How are you?
I will thank you. Well, I'm well. working. We were
Yes, Sarah. Sorry. I sent you message in chat. Can you see it?
Yes, I've copied your email and
Yeah.
I
You
will
can send it
respond.
because maybe it will be interesting for you to send the thesis to our journal about this conference. Okay. So. Okay. Aminat, you can continue. No problem.
How are you? How's your children? How is your job? How's Nigeria? It's cold in Moscow. Не слышит.
Okay. So how are you?
Oh, thank you. We were ill, Magan Habibovich, me and our children during 3 weeks by COVID. Now we're recovered, maybe. Was a conference. Before one day, only Professor Singh invited. I think next year, it will be possible to make a report to this very interesting conference and on very interesting theme. Biochronology, it's something, it was, I don't know anything about biochronology. 2-3 days ago, do you know, Sarah? And I think in our project,
I know.
We will.
I've done all my work before, but never in relation to the circadian clock. But now, maybe we can think of chronobiology. And I listened to your proposal.
We are coming to Nigeria next time.
That would be fun, sir.
And we would all stay in your house. You have a big house.
That would be great. Proud to hear your voice. It's been a real fun time. I'm grateful, sir.
There is no light on your face, so we can't make it. You are in a dark place.
Okay. I didn't think about it.
Your face.
Okay.
Show
Let me move the blind.
Oh my God.
You should have light on your face so that we can see your eyes.
Is it better now?
No.
Yes, it is better. Yeah. Yeah.
Thank you so much.
I think, Professor Singh, don't you want to make some conference maybe on behavioral factor of health in Dagestan again? What do you think about it?
Sure, it would be great. Yeah, I know we enjoyed very much. We would like to have another meeting in Rajasthan, in your hotel or resort.
We're going there. We're going there next week, and to continue the acts on rehabilitation of doctors who were in red line.